This is an operative video regarding operative tenets for microsurgical clipping of a giant unruptured, partially thrombosed PICA aneurysm at the craniocervical junction in a 60-year-old female, which was previously treated with coil embolization and presented with worsening swallowing, double vision, imbalance. And the follow-up images demonstrated a 10 millimeter recurrence of the aneurysm with compaction of the coil mass. A key point was the origin of the anterior spinal artery from the aneurysmal segment, and here on the AP angiographic views from the left vertebral artery, you can see the filling of the aneurysm base and the anterior spinal artery originating from the aneurysmal segment. The key treatment options thought about were the stent-assisted coiling, pipeline treatment of the aneurysm, but given the origin of anterior spinal artery from the segment, which would be covered by these devices, a concern was raised for possible occlusion and the large repercussions from it. Hence, microsurgical clipping was thought to be the best option. The patient was offered a far lateral craniotomy in a 3/4 prone position, a groin sheath for intraoperative angiogram, harvest of the occipital artery for a possible bypass, and hence a clip reconstruction of the aneurysm was done with an intraoperative angiogram. Here you will see the operative view with the takedown of the arachnoid at the craniocervical junction on the left, and here you can see the cranial nerves 10, 11, and vertebral artery and PICA closely associated with the partially thrombosed aneurysm. Here you can see the fluorescein injection demonstrating the anterior spinal artery from the aneurysmal segment, and you can see that the inflow vertebral artery is being retracted by the Roton 6 here. Fluorescein is very useful in demonstrating small vessels. A stacked clip construct was used with a straight fenestrated clips fenestrating the anterior spinal artery and preserving the parent vessels. An ICG was subsequently completed after placement of these clips that demonstrated patency of PICA and the vertebral artery with obliteration of the aneurysm. This is the postoperative CT, and the intraoperative angiogram demonstrating patency of the anterior spinal artery in the earlier runs, and no filling of the aneurysm. The patient made an uncomplicated postoperative recovery, had improvement of headaches and resolution of swallowing function over the ensuing 2 weeks in the rehab facility. This case is important because it demonstrates the usefulness of a far lateral craniotomy with a transcondylar exposure for large PICA aneurysms and the need for proximal control. And a key point here is the identification of anterior spinal artery and preservation in cases like these. Thank you.